We are very honored to have as today's guest and featured speaker for today's Lunch and Learn, Dr. Stephen Aradi, neurologist and movement disorder specialist. Dr. Aradi has generously offered to take his time to share his expertise and answer your questions. I would like to explain the format today, which is a bit different. First of all, as always, these Lunch and Learns are not webinars. They are opportunities for us to interact and communicate and to help each other in our journey with Parkinson's disease. So you are all muted, but when we get to the question and answer part of our Lunch and Learn, you are free to put your questions in the chat box and then we will read them out. Or you're also welcome to raise your hand. I can see all of you. And then I will call on you. You can unmute yourself and then mute yourself again in consideration for your fellow listeners. The format for today is a bit different because Dr. Aradi will begin and say some introductory remarks and share some introductory information, and then we're going to turn it over to you. So the way that this will work to maximize everybody's opportunity to ask questions, I will be moderating, and we ask that when you pose your question, accept fairly constrained responses that don't go on for half an hour so that we could be sure to get to as many questions as possible. And if necessary, I will cut you off. I don't mean to do that in any negative way, but just again, to make sure that we can get to as many questions as possible. This is a really, really unique opportunity to ask the doctor, and we are immensely grateful to Dr. Aradi. So on that note, I am going to, Dr. Aradi, I can't unmute you, so if you can unmute yourself, and I will spotlight you. And thank you, Dr. Aradi. It's all yours.
All right. Thanks so much, Panina, for the introduction, and thanks everybody for attending today. As Panina said, I think this is going to be an interesting hour, and sort of like what I was coming into this with and talking with Panina is, I feel like there are a lot of things about PD that are not obvious, and there are a lot of things, you don't know what you don't know. And so depending on what you get exposed to during your journey of diagnosis and management for Parkinson's disease, there are a lot of symptoms both related to movement and not related to movement that can come up. And a lot of times, someone may or may not be aware that something they're experiencing has a relationship to their PD and is something that they can or should ask their neurologist about. Some of these things may be familiar to a lot of you in the audience, especially if you follow either with me or some of us at the center, or had a longer experience with PD. But I kind of wanted to start a conversation about some of the things that can help the clarity of communication between you and your Parkinson's disease provider. So I'm going to try to, I just have like 2 slides that are really just a jumping off point for this and then for your questions. But I'm going to see if I can share my screen here. And despite what feels like 100 years of remote pandemic stuff, I'm still not always great at that. So can you all see a PowerPoint slide?
Yes, we can.
All right, wonderful. So as Panina said, I'm a neurologist at USF and movement disorder specialist, and one of my more specific hats is as co-director of the Huntington's Disease Center of Excellence at USF. So this first slide is I think a useful table from one of the sort of main textbooks of movement disorders that everybody who kind of goes through that pathway sort of looks at. And so I use this when I'm doing my lectures for medical students or physician's assistant students, because I think I like how it lays out motor symptoms, so movement related symptoms and non-motor symptoms. And I'm not going to read everything here because, as you can see, it's a busy table. There's a lot in here, and that's the most important take home point. there are a lot of things that can happen in PD. And, we always think about the movement symptoms with the resting tremor and slowness of movement and stiffness of movement being the sort of hallmark. And in many cases, those are the symptoms that eventually lead to a diagnosis, but there's a lot of other things that come up. I just wanted to highlight a few things that, in my experience of seeing patients, so these are things that I will ask about and that a patient may not have realized was ever relevant and may not have really spoken to or talked about in the months or couple of years before they're referred to us as a specialty center. So some of these things are, for instance, this is sialorrhea. What that means is excess saliva, and that's a symptom that comes up through the course of Parkinson's disease. The main reason why that occurs is because, just like other movements that one tries to make can be small or hesitant, or slow, other movements also can be reduced in their frequency, and so that includes swallowing. And so if one swallows less frequently, then saliva can accumulate and lead to bothersome excess saliva, and that is absolutely a symptom that you should bring up with whoever you're talking to your Parkinson's disease about, if that's something you experience, because there are lots of ways to manage that, medication and non-medication. A lot of the other ones are on the non-motor column, because again, I think that sometimes these can be de-emphasized when, especially if you have a quick appointment and someone, wants to say, well, so how's your tremor doing on the Cinemet, and how's all that going? Okay, great. But these other non-motor symptoms are oftentimes just as, if not sometimes more, relevant to somebody's day-to-day quality of life. And so behavioral or psychiatric symptoms like depression, apathy, and anxiety are absolutely fair game for addressing with somebody who's taking care of your Parkinson's disease. That doesn't mean that I or other of our colleagues aren't sometimes going to want to ask a psychiatry colleague or a psychologist to help with managing these symptoms, especially if they get complicated enough. But these are things that are absolutely part of the picture, and things that we want to be able to capture and at least talk about and come up with an approach for. Some of the other symptoms here that I highlighted are down here, falling under this box, which has this word dysautonomia. So what that refers to is a branch of our nervous system called the autonomic nervous system. And these are functions in the body that are not under our conscious control. And so these are things like maintaining our blood pressure with posture changes, controlling the muscle tone of our bladder and our bowels, helping to regulate things like sweating and lots of other things. And so Parkinson's disease affects the nervous system at multiple levels, and it absolutely affects the autonomic nervous system, in some cases very early on, and in other cases more so later on in the course. And so, one of these is constipation. That's an extremely common symptom, and sometimes, in retrospect, is maybe one of the more early things that somebody would have noticed, developed leading up to their ultimate diagnosis. But again, sometimes I run into patients who aren't aware that that's something that would be related, and maybe their doctor who's treating their Parkinson's disease initially isn't really aware of that or asking about it. And constipation has a lot of domino effects in terms of other health and just comfort and other things. So that's definitely something that I always try to address at every visit, and you should feel empowered to bring up and ask about. Similarly, hypotension means low blood pressure, and in particular, when you go from a lying or sitting position up to a standing position, when we do that positional change and gravity starts trying to, bring our blood volume down towards our gut or our legs, that would, if there wasn't an autonomic nervous system functioning to try to counteract that, then the blood would rush out of our brain. We get very lightheaded and dizzy and faint. And so that kind of positional lightheadedness is something that becomes an increasing issue in Parkinson's disease, just because of the condition and the way it affects those nerves, but also commonly is a side effect of some of the medications that we use to treat the movement symptoms. especially medications like ropinirole or Requip, pramipexole or Mirapex, and Nupro, which is reticotine. And then I put a whole box around sleep disorders because it wouldn't make sense to put a box around each and every one of these, because I think sleep is one of the things that can be affected by a number of different mechanisms that can ultimately, result in a change in our sleep patterns and quality. And so RBD stands for REM sleep behavior disorder. So this is the acting out of one's dreams during sleep. That's a condition that, again, just like constipation, can sometimes occur even before the tremor and slowness and stiffness develop. So the acting out of one's dreams during sleep impairs sleep quality and presents a risk for injury to a patient or their bed partner. And so that's also something that can be very manageable. Other problems like waking up frequently at night for lots of reasons are things that I think are important to address and pay attention to. And then finally, at the end here is restless leg syndrome. And so restless leg syndrome is a totally separate neurological condition that many people have without Parkinson's disease, but it does seem like they probably occur together a little bit more frequently. So restless leg syndrome refers to a condition in which somebody has some kind of unwanted or uncomfortable sensation in their feet and legs, particularly in the evening or at night when they're at rest and not doing anything with their feet or legs, so lying on the couch or lying in bed. And that uncomfortable feeling is temporarily relieved by moving the feet or fidgeting with the feet or legs or standing up or walking around temporarily. And so that's something that is really relevant, to sleep quality, but also again, has some relationship to some of the medications that we use to treat some of the symptoms in PD. So this is just not meant to be necessarily comprehensive, but just an illustration of the fact that there are a lot of things that can go into this. And I want everybody to feel comfortable bringing things up and sort of comfortable asking questions about, I have this thing going on that's affecting my day-to-day living. Is this possibly related to the Parkinson's and something that we should address together or not? And then this next slide is also super busy, but really I wanted to boil it down to the idea of a Parkinson's disease motor symptom glossary. Basically, just these are a lot of words that are kind of jargony, and again, many people in the audience probably do know exactly what all these words mean. Many may not, and a lot of the times that something that I'll notice, especially with people who are more recently diagnosed, perhaps there's a little bit of a vocabulary that comes with living with PD, and I think sometimes if there's a mismatch in that vocabulary, there can sometimes be miscommunications about what certain what certain parts of management are going well or not going well, and I don't necessarily need or want to really go through all of this and turn this into more of a lecture than I think it should be for this kind of a lunch and learn thing. But maybe this could be distributed and you guys can look at it, or if questions come up. But just the idea of what does it mean to talk about on time, or what does it mean to talk about off time or wearing off, and what is dyskinesia? What do I call that? Is that my tremor coming back, or is that something else? What is dystonia? What is this cramping I have in my foot and my toes, especially at night? Or is that just a Charlie horse, or is that actually this dystonia that has some specific treatments that can help? So again, this is just to sort of bridge that gap a little bit. But again, I don't want to just talk the whole time, and so I'm gonna pause and really just open it up. I mean, questions about this stuff, this slide or the previous slide, or questions that you brought to this lunch to try to ask about. And to echo Panina a little bit, I think to make this useful and helpful broadly, I think we might want to try to avoid specific questions about specific like circumstances or management questions, but really I just want to try to see what we can do to get some good conversation points going and some gaps in knowledge or questions, really whatever.
So thank you, Dr. Aradi. If you could stop sharing your screen.
Mm-hmm.
Perfect, wonderful. And now we open it up to questions. So again, if you have a question that you'd like to pose, you're welcome to raise your hand. I will see you and I will call on you. Or if you'd like to put a question into the chat box, you're welcome to do that. So so far, I don't see any questions. Oh, there we go. Harvey. Yes, please. If you can unmute yourself, I can't unmute you. There
Here
you
we
go.
go. I'm going to put me on video. There we go.
There you are.
I'm okay. Can you see me? No. Sorry about
Briefly.
We're
that.
able to briefly.
There
There
we
you
go.
go.
Hi. So I was diagnosed with Parkinson's at December of 2019. I've been really doing well. When I started to increase my dosage of carbidopa levodopa, I have a lot of abdominal cramps, which I have a strong suspicion is a reaction to the levodopa. I may be right, I may be wrong, but so far I have that problem almost every day that I have to endure those cramps. I have seen my gastroenterologist who has given me a few things. Originally, I was constipated. He gave me something for that. That's not a problem, but ever since I increased my dosage of carbidopa, levodopa, I've got these daily cramps. Any advice, suggestions?
Yeah, I think it's a great question. I'm sorry you're experiencing that. And I think it's a good question because it touches on a couple of important points here. I mean, so nausea is, one of the more common side effects of levodopa, the levodopa part of carbidopa levodopa. Is that what it feels like? Does it feel like nausea, or is it more painful cramping?
It is cramping. It's gas, excessive gas cramps.
Interesting. So have you tried to, skip a dose or try a holiday to see if it goes away?
Interesting.
Skipping a dose, I haven't tried.
It's probably not comfortable for other reasons. Your motor symptoms would worsen.
Yeah, so everything is, for the most part, I'm doing great. I don't have any cramps right now. I have a few days in a row where I don't have that. When I do have the cramps, my GP gave me a suggestion. Just a minute. So I'm taking some diclomine hydrochloride. I don't know if that's making a difference. I take Gazex. After 2 hours, everything is okay until the next time. But this is almost a daily occurrence.
Does it really follow the dose of medication? Does it seem pretty related to when you take the medication?
Yeah, often it does. And other times, like, for example, today, nothing, which I'm very happy about. And sometimes it'll only last for an hour or two, and that's it for the day. And the next day it may be okay and experience nothing. Right now, I'm doing great.
And last question: Do you have? Are there visible movements of your abdomen, of your stomach,
No,
or is it going in and out, or anything like that?
No, not that I'm aware of.
Okay, because there's an uncommon kind of dyskinesia, meaning extra involuntary movement that is related to the medication kicking in and working, called belly dancer's dyskinesia, which can cause involuntary abdominal muscle movements, and that might be uncomfortable. It doesn't sound like that. It sounds like cramping and bloating. I can't say that it's a common side effect I hear from the levodopa. I do get, nausea is common. And headaches is another one that's weird because it's not really like anywhere on the documentation, but I've got a number of patients that clearly have headaches related to it. Cramping, not so much. I So the medicine you mentioned, dicyclamine, it's also called Bentyl. That's a good anti-cramp medication. I think it's worth trying that. The other thing that I might wonder about would be probiotics. So we know that the microbiome can be affected in Parkinson's disease. We don't know the significance of that or the clinical relevance of that, if there is any, but we know that the composition of gut bacteria does change. And for instance, there is pretty good or decent evidence, I should say, for the use of probiotics in managing constipation in Parkinson's disease. So it might stand to reason that if you have a lot of bloating and gas, it might be worthwhile to try like a good probiotic.
I've tried one from my gastroenterologist had recommended.
That's not a problem.
Yeah, it is a probiotic. My wife is telling me that's not, but it says
That's peppermint, isn't it?
No. Anyways,
Um,
I have tried it. Hasn't worked so well.
Yeah,
I can try it again.
Yeah, there are other strains too. So if you ask about other like more lactobacillus or one of the other ones. Also, some people find that using more natural probiotic products like kefir which is like a fermented dairy product, might be helpful. But that's one direction I might go to think about. In terms of whether it's related to the medicine, hard to say. It doesn't sound like it routinely accompanies the dosing of the medication, which makes me think it might be somewhat unrelated. But yeah, maybe try to decrease the dose for a few days and see if that affects the symptom. But again, that will make your tremor and slowness and stiffness worse probably.
Okay,
But then you maybe think about some other probiotic formulations.
I will do that. Can I ask you one other question?
Let's actually switch to somebody else and then we can come back to you just to give someone else a chance right now. And I do request, if you're not asking a question, if you could mute yourself and then unmute yourself to ask the question, that would be helpful. So Nancy and Kevin, you can unmute yourselves. Go ahead. Yes, Nancy and Kevin. Nancy, Kevin?
Can you hear us?
Can you speak up? It's hard to hear you.
I'm on my fourth medication.
Yeah, I'm sorry. Your voice is muffled for some reason. Your audio is muffled.
Okay, let me see if you can hear me.
Okay, well, while you're trying to work that out, let's go to Alan and Glenda Sr. If you can unmute yourselves, there you go.
You mentioned depression and apathy. I'd like to hear you discuss how you manage that without getting into medicines that might become addictive.
Yeah, I think that's a great question. So treating depression and apathy can involve medications and also non-medication approaches. I find that I feel like I get the best results when patients use a combination of the two, or at least actually start with non-medication approaches. It depends a little bit too on a lot of the circumstances. Sometimes there are things that result in an appropriate situational depression or grief, or even a temporary period of like adjustment, like an adjustment disorder to a diagnosis or something changing, or really difficult transitions, like if somebody retires, maybe retires earlier than they anticipated. Those are situations where I think that talking to a counselor can be really helpful. So doing more psychotherapy or cognitive behavioral therapy, especially if you can find, with somebody who has some experience with mood symptoms that are related to medical conditions, or even Parkinson's disease specifically. There are some of those folks out there. And so, I think that approach is helpful, especially if somebody's worried about medications. Sometimes though, depression and apathy are not just strictly situational and, are related in some way to the changing brain in Parkinson's disease and other similar neurodegenerative conditions. And So, and sometimes we have to account for that by using medications to try to help restore some of those neurochemical imbalances. And you worried. Your question, indicates a concern about addictive potential or habit forming potential, and so there are some medications for anxiety and sleep that can have those qualities, like benzodiazepines, and I try to avoid those as much as I can because of that possibility. Other medications for depression, like SSRIs, which are pretty commonly used, tend not to, they don't have a habit forming potential per se. They're still medicines that you don't want to stop suddenly if you take them for more than a couple of weeks, because you can have a little bit of withdrawal syndrome, but it's not due to a sort of addiction or habit formation process. Apathy is actually a little bit of sometimes a more different beast and a little bit more difficult. If you talk to, some folks might prescribe like stimulants for apathy, things like Adderall or Ritalin, and those they have a place and they have a use, but those stimulants do have some habit forming potential or abuse potential. And so I reserve those as a second or third line option for apathy. And so again, I'll often recommend a course of counseling to sort of see about that. Some other things that can be helpful for apathy, if there's just a general lack of motivation, lack of drive to do things, are setting a schedule out for yourself. Scheduling in things like doing some tasks or chores around the house, having a regular bedtime and wake up time, and even scheduling, maybe social, a weekly social engagement or something like that. So having it on your calendar and being able to basically just default to a schedule that is set up, as opposed to having to independently come up with, here's what I'm going to do with my unstructured time today, because doing the latter can be a lot harder. So if you have something that you can refer to that basically is setting something out that you can follow, that can make that easier. Another medicine that I'll use for apathy sometimes that has a lot of use in Parkinson's disease otherwise is called amantadine. And so we use that to treat dyskinesia. It can also treat the tremor and slowness and stiffness, but apathy has a little bit of like an energizing effect that can sometimes help with that apathy or lack of motivation. And then finally, the last thing I'll say is that there is one antidepressant that can really help both of those symptoms, apathy and depression, and that's Wellbutrin or bupropion. So that can be pretty useful if somebody has a sort of combined depression and apathy. I just get careful with it in PD because sometimes it can worsen tremor a little bit, but I think for the right patient, it's definitely worth a shot.
Thank you, Dr. Aradi. I want to try Kevin and Nancy one more time, and then we're going to go to our first question in the chat box. So Kevin and Nancy, do you want to try it again?
Yes. Can you hear us?
Yes.
Okay. I'm on my fourth with my doctor. I'm on my fourth with and my side effect from day one was very strong and very weak. The other medication is this is not working for me. So we took I started the on the recycling on June 3rd. I've been having symptoms since that day.
You stopped taking it.
That's when I feel it. Did a double dose. I've been taking a half a milligram in the morning of the 1 milligram pill. So we've been doing that since early June. He said, okay, let's step up double dose of 1 milligram pill for about 2 weeks and see if it'll help with the movement. And it hasn't helped. And I've been off of that since June 16th, maybe, completely. And I still have grogginess and dizziness since like day one of taking the pill, and I'm now 3 to 4 weeks off the pill. And I wake up every day. If I pick up my head, I'm groggy and dizzy. If I walk, I'm groggy and dizzy. If I sit up, I'm groggy and dizzy. If I lay down, I'm fine. So it's like maybe in my system still, not getting out of my system. I Googled it. It said sometimes it takes saggling 2 weeks to get out of your system. For me, right now, it's been 3 and 4. I wake up every morning hoping I'm out of my system, and it's not.
I'm going to interject for just a second. I believe that Dr. Aradi was able to hear you because he's got his headphones on. The rest of us did not hear. So Dr. Aradi, in your response, if you could be aware that the rest of us did not hear the question.
Yeah, absolutely. So it was a little spotty. I'm going to repeat what I think the question to be, and if you could nod or shake your head if I've got it right. So it sounds like you were describing to me that you had side effects of fatigue and grogginess and dizziness with pretty much every medicine you've tried, I think, but particularly with this question, rasagiline, and you stopped the rasagiline in mid to late June, but nonetheless, so you've been off of it now for 5 or 6 weeks. But you still have the, sorry?
3 to 4 weeks.
3 full weeks?
Oh,
3 to 4.
Yeah. So you've been off for 3 or 4 weeks, but you still have the side effects that you were associating with the rasagiline previously. Is that correct?
Right.
Okay. So biochemically, rasagiline should not stick around in the system that long. That should be out of your system by now.
Right.
I don't recall the half-life. So there is, I'm going to actually quickly, maybe I'll get back to you because there's one version of this in which it might take a little bit longer because the way rasagiline works has it stick around a little bit longer. But I think it's unlikely that the side effects you're experiencing now, 3 to 4 weeks after being off of it entirely, I think it's unlikely that I would attribute them 100% to the rasagiline. They may be an independent set of symptoms that are part of the PD itself or something else going on. And I like in this situation, so to generalize a little bit, if somebody's stopped a medication for long enough that some symptoms that we worried were a side effect, if they're still persisting longer than I think the medicine's in the system, then I think it bears further kind of exploration to see maybe these symptoms weren't strictly side effects and maybe there's something else going on or we need a different approach to it. That's kind of where my head's going at with that question. Is that addressing the question you asked?
Yes.
In a way,
Okay.
I'm trying to balance this way of living every day, and nothing's going away from me, and I'm very, every day I wake up, I'm just very frustrated. And I try to be physically active with myself, with my wife. We both walk every day, we bike every day, I swim every day, and it makes it such an obstacle because I'm not doing it with a free mind. I'm doing it. What it makes me feel like is if I just took a sleeping pill and I just got drunk, and that's how I spend my day. And it's from AM. It's not even like it dissolves out of my system towards the evening. It doesn't go away at all until I lay down.
Okay.
So it's not going through well.
Yeah, yeah, that's tough. Let's follow up on this after. Okay.
Thank you. Thank you, Dr. Aradi. So the next question comes from the chat box. Enid is asking if you could talk about toe deformities.
Yeah. Okay. So so one of the things that was on that second slide is dystonia, and dystonia is an involuntary muscle contraction that causes posturing, so pulling, twisting, or posturing of body parts. And a very common location for that to occur in Parkinson's disease is in the foot and the toes. And in fact, a very classic way for that to present in the foot is with the big toe deviating upwards and sort of pointing up at the ceiling and pushing up into the shoe, and that can be really uncomfortable. It can end up leading to things like ingrown toenails and other problems with the toe because it's being pushed up and forced up that way. And we call that a striatal toe, but it doesn't matter what it's called. So that's a very common thing that can happen, and there are ways to treat that. If in fact it's that kind of a problem from a dystonia where it's going up or if it's curling down into the shoe. That's where my head first goes when I think about this in PD. There can be some other orthopedic changes that happen in the feet with Parkinson's disease, just especially if it's affecting the mobility and posture of somebody's foot and how their foot and their toes sort of fit in the shoe and where those points of pressure and friction are being applied to the toe joints and the foot joints. So if it doesn't actually look so much like a like an involuntary posturing and pulling and dystonia problem, which would be treated in one way. If it instead looks more orthopedic, then I would probably reach out to a podiatry or orthopedic surgeon colleague to see if there are things that we could try to do to help with that. You know, something maybe as simple as an orthotic in the shoe, or a different kind of shoe or footwear, or something that's open-toed. Or if there's something else that needs to be done, like addressing a bunion or something. Do you have any thought as to which of those two is going on? Is it the
Yeah, no, it's
dystonia
not-
problem?
Can you hear me?
Yes.
Yes.
Okay, good. Well, my small toes are curling under, and the big toe suddenly just started going off to the side, and it got infected also, and nobody seemed to, this was before I was diagnosed, and it just, in 6 weeks, my toe looked completely different, but it's not going up. But I can't wear shoes either. I mean, I can only wear elastic type shoes. And now I think it's starting to happen to my other big toe, but it's not going up. It's kind of just, it's going, the last joint is pointing up a little bit like this. So, but it's very uncomfortable. Plus I have neuropathy from having chemotherapy. So it's a miserable condition. It stops me from walking very much.
I'm very sorry. Yeah, that sounds really hard. Is the foot that's most affected the side that you developed the Parkinson's symptoms on initially?
No.
Oh, okay. I mean, it sounds like the toe curling and the deviation of the toe certainly could be dystonia, and the way that we would treat that would be with botulinum toxin injections. It's also possible that people with neuropathy, usually more so from diabetes, but neuropathy of any kind, can lead to repetitive small injuries and skin breaks and inflammatory changes, something called a Charcot foot, which needs to be treated in a different manner.
Okay, and I have one little quick question. How do we get in touch with you if we want to see you?
So what we could do is, Panina, do you have the center phone number?
Yes, I do.
Okay, maybe Panina can share that, because I don't know it off the top of my head.
Okay,
But
that's fine. Thank
yeah,
you.
of course.
Thank you, Dr. Aradi. So we have a question from Dinesh. And yeah, if you can unmute yourselves, go ahead, Vandan.
Hi, I'm Dinesh's wife, Vandan. He had a question regarding, he's been having a lot of odynophagia for the last 6 to 8 months, and we haven't been able to figure out what's causing it.
So sorry to interrupt. Did you say odynophagia? So like painful
Pain
eating
with
and swallowing?
He
Okay.
complains of throat pain when he swallows.
Gotcha.
He doesn't have any globus sensation, doesn't feel like something's there. We have been through we have done an ENT evaluation, we have done, and nothing seems to, they're all thinking it's GI related or maybe reflux. We have tried 3 different reflux medicine and nothing seems to be taking it away. So his question is, he started sertraline around the same time when this pain started. So he's kind of trying to associate it with sertraline. So his question is, can sertraline cause GI related issues to the point where he may have odynophagia?
It's a great question. Again, sorry that you're going through that. SSRIs and sertraline can cause gastrointestinal symptoms. Normally what I see in practice and sort of know is reported as nausea, but it would not surprise me that in some people it can alter bowel habits. For instance, I am not aware of a side effect or adverse effect of an SSRI that would be expected to cause odynophagia, unless pills are getting stuck in the throat and irritating the esophageal lining and causing an esophagitis in that sense. A number of medications can do that if they don't transit through the esophagus efficiently. If they stick there, they can irritate the lining. Is it more of a back of the throat or mouth pain, or is it like here? It's here.
Complaints lower in his throat. Yeah.
Yeah. Unfortunately, the best that I could do would be to say, CGI. I mean, the first things I'd be thinking of are things that you'd look for on an upper endoscopy, which I'm sure he's had already, right?
No, we are in the process of getting an upper endoscopy as well as a manometric study.
I think that's the first place to go, because it sounds like a stricture or a motility problem, or even certain kinds of infections can cause this symptom that they'd be able to see on the EGD. So I'm not aware of this being an SSRI related thing, but
Okay, thank you.
of course.
Again, another question. What can you suggest for drooling or siluria, which is non-medication? Any suggestions of what can be done for treatment?
Yeah, the first line that I always start with, usually for patients, unless it's like really severe, is using chewing gum or hard candies or lozenges, sugar-free if necessary, but maybe don't go too hard on those for other gastrointestinal reasons. But those are all things that stimulate swallowing at a higher rate than you would otherwise. And so those are things that can help to reduce the pooling of saliva.
Okay, so thank you, Dr. Aradi. We have a question from Jiva. She asks, what is the upper limit on per day Cinemet use?
Great question. Yeah, I mean, I, in my practice, tend not to take people any higher than about 2,000 milligrams per day. And that's for Cinemet carbidopa-levodopa. That's different for Rytari, which is also carbidopa-levodopa, but it's a different formulation. So the dosages for Rytari are higher than that. The maximum levodopa per day based on the package insert for Rytari is higher, is I think somewhere in, it's well above 2,000 milligrams. I don't remember the number off the top of my head, but for Cinemet, I try not to go higher than 2,000 milligrams per day of the levodopa part of that. There's the 25/100. So the second number, I try not to get higher than 2,000.
Thank you. So we have a hand raised, Deta Juju. I don't know who that is, so if you can unmute yourselves.
Hi, can you hear me?
Mhm.
I'm sorry, we forgot to sign in. We're new to your group. This is my husband, Doug, and I'm Judy. And we have a question, two-part question. One is on your motor side of your chart, the third one down with the decreased arm spring, shuffling gait, freezing, difficulty rising from the chair, and turning in the bed. In addition to the non-motor, just constipation, pretty much some also urine issues as well. Okay, if you have just that and none of the other motor skills, they're speculating that it's called Parkinsonianism and not Parkinson's. Can you have just that, and be treated with carbidopa-levodopa to help this particular freezing of it? Because right now, just to fill you totally in, we're trying to he's practically off of the carbidopa-levodopa because it didn't seem to change any of the freezing whatsoever. He had no symptoms of bad things happening with it, but we just figured one less was okay. The only thing that is happening, he's down to like a half a pill a day, is that he is tending to fall more. Okay. He feels like he's falling backwards a bit. So that's our only issue. First question, can you just have those symptoms and still have Parkinson's, or what? What do you think about that?
Yeah, I think it's a great question, and it's something that would bear including in a more comprehensive, like, kind of basics PowerPoint or something. Yeah, so Parkinsonism is, when you have the suffix ism, means it's just a set of clinical signs on the neurological examination of slow and small movement plus tremor or rigidity, and then usually there's some change in walking and mobility. So Parkinsonism is you can kind of think of it as like a set of symptoms that could have lots of different causes of it. So a headache is a symptom, but you could have a migraine, you could have a sinus headache, you could have a tension headache, lots of different things. So that's true of the signs of Parkinsonism. Parkinson's disease is a specific brain condition, a specific neurodegenerative condition that can can be diagnosed definitively. The only way to really do that right now is to look at brain tissue under a microscope, but Parkinson's disease implies a specific condition. There are other conditions that could cause somebody to have Parkinsonism that looks like what you're describing. And, if other reversible causes of that have been ruled out, so, getting an imaging of the brain, make sure there's not something scary like a mass or a lot of strokes or something else that might do that, or making sure that there aren't any medications that are being prescribed that can cause those symptoms. Then you're left with, this is probably a neurodegenerative condition, but is it Parkinson's disease, or is it one of what we call atypical Parkinsonian conditions? Those are a handful of other neurodegenerative diseases that can, like you said, share some of the things, some of the signs on that table, but maybe not all of them, and maybe not in the way that we classically think Parkinson's disease should look. And so in cases like that, what will, we really just do exactly what it sounds like you guys have gone through, which is treat this as though it's Parkinson's disease, because the atypical conditions and Parkinson's disease itself really have the same treatment approaches available to them. And so some of those people who have the more atypical looking Parkinsonism can still have a beneficial response to medication. And so it's almost always worth trying. One of the other asterisks to this is that sometimes some of those patients who have those other neurodegenerative conditions can get a beneficial response to medication, but sometimes it requires much higher doses and sticking with a trial for longer. So sometimes up even as high as 1,000 milligrams of that levodopa a day. So yeah, the answer to your question is somebody can still have Parkinson's disease and look in the way that you described in that picture. Somebody may instead, with that constellation, have one of the atypical conditions. Right now, there aren't any necessarily definitive ways to prove that per se, other than following things over time. And scientists are working really hard to come up with other ways to make those distinctions. But otherwise, just treat everything the same, because we have the same tools, and sometimes they'll all work in the same way.
Thank you. One more thing. The
Can we
reason he went
actually-
on. Oh, go ahead. I'm sorry.
Sorry, yeah, let's shift, because we do have questions,
Okay.
and if we have time, we'll get back to your
course.
second one.
Of course.
I'd like to get to Alan and Glenda Senior, and then we'll get to the next question in the chat box. So Alan and Glenda, if you can unmute yourselves.
So you mentioned cramping of the feet at night. And what do you suggest can be done about it?
Yeah. So so cramping of the feet at night could be just Charlie horses, which, we try to treat with making sure you're hydrated. Electrolytes like magnesium can sometimes help, having a banana, things like that. There are sometimes some medicines that can help, but if it's not just Charlie horses, and in Parkinson's disease, I'm always more worried that it's dystonia. That's where there's, if that cramping is associated with the toes usually curling in or sometimes fanning out. So if the toes are curling, and then if the foot is sort of like pointed and then kind of turning in. So if there's that sort of posturing of the foot with these symptoms, that sounds more so like dystonia. And really the best way to treat that is to use botulinum toxin injections. So the brand name everybody knows of that is Botox. There are other brands, but the way that medicine works is you inject a small amount of the medicine into the muscles that appear to be most responsible for that particular pulling and posturing. And the medication induces a certain amount of weakness. The way that it works is it causes that muscle to get a little bit weaker. And so you aim to really target a Goldilocks range of weakness in just those related muscles. And these injections are approved to be done every 3 months. And so the effects can last anywhere from a few weeks to 12 weeks and provide that kind of sustained relief with the ongoing injections. So that's I do that pretty frequently, and others in our practice do. So that's where I would maybe go with that.
So I'm going to actually skip to a question that's related from Trish. She asks, are hammer toes related to PD? I'm having trouble with one on each foot that affect my gait and are very painful.
Yeah, this kind of gets to the earlier question about this too, which is that, I can't say, can everyone hear me still, by the way? My computer's telling me my internet connection's unstable.
It's good.
There you go.
Okay, good, thanks. So this is maybe I'm going to look this up after this call because it's come up enough. You know, is there a higher incidence of orthopedic foot?
Oh, yeah, we are losing you. Uh-oh. Dr. Aradi? Testing 1, 2. Okay. Well, hopefully he will reanimate. Yeah, there's nothing that we can do about an unstable internet connection at the other end.
You can try turning off his video. That may improve his audio.
Dr. Aradi, let's just give him another minute. All right, well, I will stop the video. Oh, he's getting off and he's going to get back on, I think.
Can you all hear me?
Oh, yes, lovely.
Okay, great.
Thank you.
Sorry about that. I don't know why that happened. So I was saying that I think it's a great question, and now that it's come up a couple of times, I'm going to look into this. But it wouldn't surprise me if the rate of orthopedic foot changes is higher in people with Parkinson's disease compared to people who don't. I don't actually know that to be true, but I would guess it probably is. I think that for the most part, treating these orthopedic foot changes wouldn't really be different in somebody who has Parkinson's compared to somebody who doesn't. We use the same approaches. I think that the ways in which that could be different are if we think that there's a lot of dystonia that's causing repetitive twisting stresses on a foot joint or a toe joint, then we should account for that contributor by treating the dystonia with oral medications or with botulinum toxin injections. But for hammer toes, bunions, things like that, I think it's really kind of the same way you would treat that in anybody else, would be my guess.
Thank you, Dr. Aradi. So, let me just mute Glenda because her phone's ringing. So there's a question in the chat box from Wayne. He says, I know quite a number of people who are unhappy with the care they are getting from their neurologist. Doesn't listen to them, see their PA more than the doctor, etc. What would you advise them to get this addressed? How to broach the subject?
I think that's a great question, and it's a tough question. And it is something that I think applies really across medicine. So in my practice, I don't practice with an advanced practice practitioner, an NP or a PA. But a lot of my colleagues in the department do across all of neurology, all subspecialties, not just movement disorders. And in talking to my patients, when they see other specialties, gastroenterology, cardiology, dermatology, there is a real change across the entire field of medicine in terms of changes in how care is delivered. And one of the biggest front-facing changes is the increasing rise of what we call mid-level providers or advanced practice providers, physicians, assistants, and nurse practitioners. A lot of this is driven by two things. One is physician shortages, and that's especially true in neurology and movement disorders. Every year there are advanced fellowship training spots across the country that don't get filled. For a variety of reasons, there's a shortage. And as many of you guys may know, our wait lists at USF, even though I was hired in the last couple of years, we hired another part-time provider, our wait lists are 6 months out. So there's a shortage for one. And for two, there are very unsavory economic pressures in medicine that make PAs and nurse practitioners more economically favorable for a department or a practice. So there's a lot of these pressures on that issue. And I will say that a lot of the PAs and NPs that I have the opportunity to work with are fantastic practitioners in their own right, and are really excellent, and I would trust them with my care. That said, I think one of the things that can be difficult is if somebody's expectation is that they're going to be seeing a certain person, if their appointment is under a certain person's name, and then they see somebody else. I think that there's a that is maybe a more unfortunate issue of transparency, and more open communication would help with that situation. I would say, from your standpoint as a patient, you absolutely have the right always to advocate for your care and what you think, you know, your needs are, and you always have the right to know who you're going to see ahead of time and to ask that question. And to say that, you know, I have some questions that I would like to ask of, you know, this other practitioner who I've, you know, seen in the past, or who my understanding was that I would be following up with. And neither you nor I can ever control how anyone responds to that, but you have every right to ask that and to say that. But yeah, this is something, again, that is really just across all of medicine, and I think it's difficult. Is that a helpful answer? I don't know.
Yeah, in that, you know, I'm really asking for the benefit of others. I talk to a lot of people with Parkinson's, and, you know, it's one of the most, you know, prevalent complaints I hear quite a bit, you know, is they're just unhappy with the level of care they're getting.
Yeah.
You know, and they're not quite sure what to do about it, you know?
Thank you, Dr. Aradi. So there's another question in the chat box from Ruben. He asks if you can speak to caffeine use. He's heard that caffeine is beneficial, but he has the opposite effect. It seems to cancel out his medicine.
Sure. So there's a lot of evidence on big population level studies when we look at Medicare databases and other big surveys and stuff, and we think there's a consistent signal that people who drink, you know, more than three or four at least cups of coffee a day have a lower risk of Parkinson's disease. These associations are extremely difficult, if not impossible, to prove in the way that we can prove that a medicine has a certain effect by doing a 6-month-long placebo-controlled trial. But we have some suggestion that, you know, points towards there being some sort of protective effect of caffeine. So we also don't see any real signal that caffeine is harmful, or, you know, for the Parkinson's disease process or the brain in any particular way. So I always say, if people want to and can, go for it, drink your coffee. If you personally find that not to be the case, then I don't think that's any cause for worry or concern in the long run. Just don't drink the coffee, I think. I think that, you know, one of the things is, you know, food can impair the absorption of carbidopa, of the levodopa part of the medication. So if you're having coffee with a snack or food, that might cause the effect you're seeing. But otherwise, I'm not aware of caffeine itself counteracting the brain effects of levodopa, you know, to my knowledge. But if that's your lived experience, then ex-nay the coffee.
Thank you, Dr. Reddy. I think this will be the last question. It's from Trish in the chat box regarding salariya, if I pronounce that correctly. What about overnight drooling? I soak my pillow and sheets every night. I lay out towels to soak up the saliva, but would rather not drool at all. I can't monitor swallowing while asleep.
Yeah, absolutely. Yeah. So in cases like that, we kind of have to look towards medication options, and there are 3 big ones. One is a drop called atropine, which I don't like in most cases because it can increase the risk of falls and confusion if it's used regularly. But a drop or 2 of that under the tongue at bedtime would probably help. We just need to be cautious with it. The second oral medication is called glycopyrrolate, and that's a pill, and that is probably safer from a balance and cognition standpoint, and that's available as a prescription. The third thing is, again, actually botulinum toxin injection. So just like for dystonia, the way that medicine works, it can also block the signal to saliva glands to produce and release saliva. So you can have injections to the salivary glands here on either side at the angle of the jaw, and then underneath here every 3 months, and that can reduce saliva production. You know, none of these are a silver bullet, but these are all options available to try to see if that can be helped.
Thank you so much, Dr. Aradi, for being so generous with your time and sharing your knowledge. We appreciate it greatly. Sorry that we didn't get to everybody's questions. Maybe you'll come back and do it again. I don't know. It would be lovely.
Yeah.
That would really genuinely be lovely. I'd like to point out that in the chat box, there are a few pieces. I will, if you've registered ahead of time with me, I will send out Dr. Aradi's or the clinic's phone number. If you're on and you did not register, you can reach out to me, contact me, and I will send it to you. My contact information is in the chat box. There's also a link to the program website for the JCC's Parkinson's program. There's a file with a document that describes the program. There's also a link to a wonderful foundation that one of our participants, Wayne McLaughlin, has set up. It's a foundation that provides support, financial support to people in need of financial assistance. A link to his website is there. So it's way up at the beginning of the chat string. I'll leave the chat box open for a while so that you can find it and click on it. And in the meantime, thank you all for coming. Stay tuned, and all the best of luck to everybody. Take care.
Thank you so much.
Thank you.
Thanks so much, everybody.
Thank you, Dr.
Thank you, Dr. Aradi.
Thank you. All right.